Welcome to this presentation. Today I will show you that prostate size and flow rate can predict absence of outflow obstruction. There are no disclosures for this work. Urodynamics is the gold standard in the diagnosis of bladder outflow obstruction in patients with benign prostatic enlargement. In the past, not much effort had made to improve the clinical method for diagnosing. Only men with a very large prostate were transmitted to surgery. Decades ago, alternatives to surgery were not available, but today there's a large number of alternative treatments, and the barrier to seeking medical care seems to lower. I aim to improve clinical diagnosis. Selection criteria are needed to take advantage of less invasive therapies and to handle the low barrier of seeking care. Improving the clinical diagnosis is increasingly relevant for the stratification of patients. Patients who cannot be treated medically or conservatively may be eligible for surgery or one of the other invasive treatments to treat bladder outflow obstruction. However, these treatments are aimed to reduce bladder outflow obstruction, and so that should be present for these treatments. And symptoms are not a good predictor of the existence of bladder outflow obstruction. Clinical assessment in secondary care, in addition to the bladder diary, assessment of flow rate and prostate residual are mandatory, and prostate size determination is an optional test. We assess the value of flowmetry and prostate size for the non-invasive diagnosis of bladder outflow obstruction compared with urodynamic diagnosis. We had a set of 760 men referred with signs and symptoms of lower Utrecht dysfunction and prostate sizes. Patients unable to void during urodynamics were not included, and all patients were normal with clean urine. The urodynamics was done as usual, ICS standard. Voiding was allowed in standing position for most of the patients. These were men, as you all see, average age 70 years and Qmax of around 10 and a prostate size of around 42 and a mean IPSS of 17. We try to figure out what the value of Qmax and prostate volume were to predict bladder outflow obstruction, and Pearson correlation coefficients of Qmax and prostate volume showed a good correlation with bladder outflow obstruction, and also post-void residual and voided volume had an acceptable correlation with bladder outflow obstruction. So we have, based on these statistics, with a kind of predictive modeling and very simplified the result, a clinical prostate care score that we based on measured prostate size and Qmax, and that is, the result was prostate volume minus 3 times Qmax is a clinical prostate score. And what was a predictive value of this? Further analysis demonstrated that with this index, 226 of the 265 men without bladder outflow obstruction could be predicted correctly when the clinical prostate score was negative. So, in other words, when Qmax times 3 multiplied by 3 is larger than the prostate volume in milliliters, the chance that a man has no bladder outflow obstruction is 90%, and that's better than any predictor that we have at present. So 39 were falsely predicted to have no bladder outflow obstruction, but they had a low grade of outflow obstruction. If the score was positive, 3 times Qmax is lower than prostate volume in cubic centimeter, also 36% had no bladder outflow obstruction. So the score is sensitive but not perfectly specific. The sensitivity of clips to detect bladder outflow obstruction is high, and the sensitivity is of especially IPSS to detect bladder outflow obstruction is very much lower. It's less than 50% here in our data. So you see the ROC curve, and that shows that the clinical prostate score has a very high sensitivity and an acceptable sensitivity specificity. We show these curves and see that the clips has an area under the curve of 0.85, which is very good. Combining prostate measured volume and Qmax provides a simple means to exclude bladder outflow obstruction in men with symptoms and signs of lower urinary tract dysfunction. This is a useful rule of thumb to exclude the patient from invasive management and from the necessity of invasive diagnosis. Prostate size should be mandatory as assessment in guidelines, and the rule of thumb is when the Qmax multiplied by 3 is larger than the prostate volume in milliliters, minus conservative. Conclusive measures is when a combination of prostate volume and Qmax was a reliable prediction of the absence of bladder outflow obstruction. When the Qmax times 3 is larger than the size of the prostate in milliliters. Thank you for your attention.